Pulsed electromagnetic or ultrasound stimulation can be used to encourage bone healing, although the evidence for their effectiveness remains sparse. A recent systematic review and meta-analysis identified that low-intensity pulsed ultrasound stimulates bone healing in fresh fractures, and found weak evidence of radiographic healing of delayed unions and non-union. Various orthoses are used to help try to limit the amount of load to the injured structure. Below-knee walking boots are frequently used, as are crutches. A pneumatic leg brace is often used in tibial stress fractures. This type of brace can shift a portion of the weight-bearing load from the tibia to the surrounding soft tissues, which results in less impact load being placed through the fracture site. This allows earlier bone healing while maintaining modified activity. It also gives pain control and may stimulate healing through its compressive effect. As you will see, in subsequent lessons, surgery is indicated in the treatment of some stress fractures. In some situations, this is a more predictable treatment option. As a result, it might be considered first-line treatment in professional players, but reserved for failed conservative treatment in recreational players. Stress fractures can theoretically occur in any bone. The majority of these injuries are uncomplicated, and heal predictably with a period of rest. Good examples of these injuries include most metatarsal shaft fractures, posteromedial tibial stress fractures, and injuries involving the fibula. Some of these injuries, such as those involving the femoral neck or navicular, carry a higher risk of non-union or complete fracture. The management of high-risk fractures requires the clinician to be more aggressive. These injuries require further investigation and often more specialized treatment. What makes an injury high risk? Bone stress injuries which are characterized as being high risk are either more prone to non-union, have significant consequences if they are allowed to progress to a complete fracture, or share both of these characteristics. A navicular stress injury is characterized as high risk if it is very unlikely to heal without a period of 6 weeks of non-weight-bearing rest. In contrast, a femoral neck stress fracture is considered high risk largely because if it is allowed to progress to complete fracture, it can cause avascular necrosis of the femoral head and a catastrophic injury to the femoral head. Injuries to the second and third metatarsal shafts, march fractures, are a good example of a low-risk stress fracture. A clinician can be relatively cavalier when treating these injuries. This is because they are less likely to progress to a complete fracture and because they generally heal quite predictably. In many cases, these injuries can be treated with a relatively short period of weight-bearing rest. In some cases, the athlete may continue to play competitive matches, but alter his or her training intensity and volumes to manage the symptoms. Low-risk stress fractures. An injury to the second and third metatarsal shaft is a good example of a low-risk stress fracture. Metatarsal. Athletes who experience a metatarsal stress fracture often report a history of a change in training volume, intensity, or training activity, or a combination of these factors. The most common sites are the second and fifth metatarsals. The fifth metatarsal is the second most common metatarsal that reliable to stress fracture. The diaphysis can be exposed to excess loading and fracture. This is the case in a Jones fracture. These typically heal poorly and require different treatment. These are considered later with the high-risk injuries. The neck of the second metatarsal is commonly involved. Its long narrow shaft predisposes this bone to injury as impact loads get redistributed from other areas of the foot. This happens most frequently in a pronating foot, where the first ray lies in a dorsiflexed position, transferring load to the second metatarsal from mid-stance. Another foot prone to stress fracture is a Morton's foot, where the extended length of the second metatarsal and its immobile base, locked proximally in the cuneiform bones, results in a bending torque in the bone and ultimately a stress fracture. Treatment. Treatment of metatarsal shaft stress fractures is primarily through load reduction. These injuries generally do not require prolonged periods of immobilization or non-weight bearing. The clinician should